Dr. Vinay, I would request you to please go ahead with your talk about everything about patch grafts.
Thanks, Veda. So, what are patch grafts? A living or synthetic material used to repair a defect. That is a definition of patch graft. So, ideally, it should provide volume replacement where it is required, provide good tectonic support, should maintain the integrity of the globe, and should promote healing or should result in scarring. So, patch grafts can be synthetic, and what we most commonly use is the cyanoacrylate glue. Biologic glue is fibrin glue. Then, you know, as you can see in this, all you see here can be used. You can use the cornea, you can use the conjunctiva, you can use the tenons. Monocular biologics, amniotic membrane, mucous membrane graft. Then you have a whole set of other things which I have never used actually. You know, pericardium, periosteum, fasciolata, split skin graft. All these have been described. So glue, again, a lot of indications, and basically it can be used for on the surface. Okay, for any case where there is a thinning or a descemetocele small perforations, 2 to 3 millimeters can be easily handled. Then lacerations, also all sorts of things. The mechanism is these are all liquid monomers which kind of causes results in polymerization when it comes in contact with water. So water is essential, but then we always dry the surface. The procedure mostly is done under topical. What is most important when we do glue is to debride the surface of the epithelium and the necrotic tissue, and then dry it. There will always be a thin layer of fluid or water whenever, even if we dry the maximum. So apply a thin layer. Various techniques are there, and this is the most important step in any wherever you glue. Debride, so you get a healthy or as normal stroma and surrounding structure. Then the glue, this is the handle of a PVS sponge. You can apply a thin layer, or even you can use it using a small uh, cannula or 30 gauge needle. So basically, you leave it till it heals. And how do you know whether it has healed or not? Is with the vascularization. So that is the disadvantage. Poor biocompatibility, more inflammation induced vascularization, and can be used only on the surface. So, but tectonic strength is quite good, cheap and easily available. Now, fibrin glue, on the other hand, is biologic. It's nothing but basically the clot devoid of RBCs. The problem here is, it is a little expensive. Tensile strength is very low, and it gets degraded fast as it is biodegradable. Usually, it is used as an adjunct with other things and not as per se as something to seal anything. Now, when you compare cyanoacrylate and fibrin glue, the main thing is fibrin glue is less expensive, and cyanoacrylate is less expensive, give good tectonic support, while fibrin glue is used as an adjunct with other things. So then amniotic membrane, various uses of this. We are concerned about the tectonic part where it can be used as a multi-layered. Here again, you have to debride the surface well, and then using fibrin glue you can fix it. Multi-layered, the thinner area you can actually put stacks of amniotic membrane and then cover the whole thing with amniotic membrane. Can be used for small perforations also. The advantage, as we all know, it can act as a basement membrane replacement, so epithelialization happens. Multi-layered helps in stromal augmentation slightly, can act as biological bandage, has got properties like anti-inflammatory, antibacterial. It's non-immunogenic. The disadvantage for a tectonic procedure is that it's of low tensile strength. Availability can be an issue, and it has to be, it is reasonably expensive. Then conjunctiva can be used as a pedicle graft or as a total hooding, Gunderson's flap. uh, Various indications, again, as therapeutic in infective or non-infective ulcers. Then if there is a perforation, you can use a tectonic on the cornea, or even on the sclera you can mobilize it. Problem is, when you use it on the cornea, it can cause vascularization, affect vision, and then cosmesis is definitely an issue here. Then comes the major one where we use a cornea for tectonic purpose. It is a reasonably good because you're not really bothered about the cornea quality, or then it can be used when it is stored in any medium, including glycerin. Any case of melt or thinning of the cornea, sclera, or any structure, we can use cornea. That is the advantage of cornea. Provides good tectonic support and easy to handle because we are used to handling cornea so much. So handling, dissecting is quite easy. The disadvantage is, again, availability can be a problem. Then when we use it, we have to decide whether you need a full thickness or a partial thickness, a lamella. In various conditions, you may have to fashion it into different shape. uh, Dissection, uh, basic principle is we need to have create vertical edges and then create the graft to fit into the defect and fix it with either fibrin or sutures. This is a peripheral ulcerative keratitis where we had to do a D shape, and as Rishi showed, most of these cases you don't need a sharp dissection to remove the deeper layers which already inflamed. The adhesion will be very loose. You can just use a iris repositor. And uh, this was sutured. And then this is another case where post pterygium scleral melt, where cornea was used. So in for sclera also you can use cornea as a patch graft. The sclera as a patch graft is used when there is a problem with the sclera, not a good option for corneal thinning. The advantage is provides excellent tectonic support. We can store it for long, so the availability is much easier than cornea. Disadvantage, again, many of the eye banks now doesn't process sclera, so availability of sclera is little difficult. Here also we have to decide whether it's a lamellar or full thickness which we need to use. And one important point when using scleral patch graft compared to cornea is that this has to be covered with a vascular structure. Either vascular tenons or conjunctiva has to be used, because otherwise the exposure will cause scleral melt, because it is going to take epithelialization, time for epithelialization here. So other group is corneoscleral, where you can use a cornea and sclera together, and this is a post trab infection of the section, and terrible probably melt of the avascularity of the conjunctiva. I don't know whether the conjunctival problem is because of the overuse of mitomycin, but then within 2 weeks of surgery, whether that happens is a question. So here we have used a corneoscleral graft, the sclera to match the limbus actually, and then the scleral part is again covered with the tenons and conjunctiva. In addition to any therapeutic, at times you may need to use it for cosmesis also, like in this girl with dermoid. Again, here also we have used a corneoscleral, the sclera to match the sclera, the limbus to limbus. Then finally, the new kid in the block, the tenons, which has come up now. Again, it can be used for corneal thinning and descemetocele. It is said that up to perforations of 6 millimeter you can use it. The advantage is it's always available, autologous or non-immunogenic, inexpensive because you're taking it from the same eye. Okay, gives good volume replacement, and it's an excellent option in uncontrolled autoimmune and inflammatory conditions of the eye with melt, but it is not an option in infections. Okay, and the tectonic support provided is very not as good as the other ones. Okay, so here once you do the transplant, if there is a perforation, you have to make sure you leave the eye a little soft. If you really form the AC and tighten the globe, there will be leak, and it actually favors, and you will have a flat globe flat AC the next day. What I generally do is I generally dissect around the area of thinning or perforation to create a pocket, and then tuck it in, and then take overlay sutures. Of course, if possible, do a fibrin glue at the base so your tenons is stable there. Otherwise, tucking in can be a little difficult. Yeah. Thank you.
Thank you so much, Dr. Vinay. That was a really very extensive talk. You've covered almost everything. Uh, I completely agree with you, that tenons really doesn't do well in infections. But any thoughts on it as to why it doesn't do well?
Probably the organisms spread to it. I don't know.
Yeah.
We've never actually looked at why. We've not taken the tenons and seen whether that grows organisms or what is happening there. No.
Yeah, because I agree with you. It doesn't, that's not an option that you really want to consider when you have an infection cases. And as you rightly pointed out, I think scleral patch graft, the most important thing is covering it with a vascular pedicle, getting the tenons and conjunctiva over it really, really helps. Rishi, I think you have a question.
I have a small question, Vinay. In peripheral ulcerative keratitis, specifically Murins, we know that the melting happens in the peripheral cornea and the sclera is perfectly okay, right? Do you think there could be a case for using sclera in the peripheral cornea? Because any peripheral corneal graft you put will again eventually melt if the disease is still active.
See, in any of the peripheral ulcerative keratitis, whether it's Morans or other thing, before you, unless it is a frank perforation, you have to get the disease process under control before you intervene.
Agreed. So if you have
Okay.
done that and then you're going to do a graft,
Yeah.
do you think there could be a case
Does
to
it
put
really work?
sclera?
I don't know. I've never tried it, but
I
then
actually heard a free paper about it somewhere. That's the reason I'm
that's an
asking.
interesting concept, but
Yeah,
cosmetically it is going to be horrible.
yeah, it
But
won't look good.
I think Rishi, here we are dealing with an autoimmune condition. So the minute you are putting somebody else's tissue in the body, probably the autoimmune thing will not work on it, and it doesn't matter whether you're putting a cornea or a sclera, because this is somebody else's tissue. And
So
PUK
it
is
will
an
anyway.
autoimmune, yeah, PUK is an autoimmune disorder. So your body is fighting against your tissue. So
Right.
probably, I don't
Don't
know.
know.
Dr. Geeta, you have any thoughts on that?
The general assumption in Murans and PUK is that because your corneal autoantigens have been replaced by an alloantigen, the target over there is now being replaced, and therefore the risk of melt in the transplanted tissue is much lesser, and the melts that you get is in a newer area rather than in the affected area. But yes, this is an area which we could explore further.